Hello, and welcome to the ALCSI podcast, where we share the stories of lung cancer patients and their caregivers, as well as the work of doctors and researchers in the field. Today, we have the great honor and privilege of having Dr. Drew Moghanaki with us. Dr. Moghanaki is the Chief of Thoracic Oncology at UCLA's Health Department Radiation Oncology and co-directs the VA Greater Los Angeles Lung Precision Oncology program. He is well recognized for his expertise in radiation therapy treatments for patients with non-small cell lung cancer, small cell lung cancer, and thymoma. Dr. Moghanaki has also been working on lung cancer research and leads multiple national research efforts, including the VALOR Phase 3 clinical trial, which investigates stereotactic body radiation therapy or stereotactic ablative radiotherapy as a safer or more effective alternative to surgery. So, Dr. Moghanaki, we are so honored to have you on our podcast today. Thank you for your time.
Yeah, thanks for having me. Lovely to have a fireside chat with you guys.
Well, we're really excited to share all of your expertise with our listeners. And to introduce our moderators today, my name is Priyanka Senthil.
My name is Jacob Rashap.
My name is Pranav Mandyam.
And I'm Sam Schwartz, and we are the American Lung Cancer Screening Initiative, a national 501c3 nonprofit working to raise awareness of lung cancer and lung cancer screening. So, to get us started off, Dr. Moghanaki, can you tell us a little bit about yourself?
Sure. I'm a late bloomer in through the medical education system. I actually ended up getting a master's degree in epidemiology from here at UCLA before I started my 25-year journey after that through medical school residency and 2 previous positions before coming back to LA, where I was recruited to help lead the lung cancer program in the Department of Radiation Oncology. Yeah, I mean, I've been very passionate about being an academician. I've tried very hard to think about working in community practice. It just doesn't feel like the right fit. So I'm probably gonna end up dying in a hospital and never retire at my current rate.
Thanks for that introduction. You kind of already got into this, but we were just wondering how you got into the field of radiation oncology, if that was always where your vision had been in terms of medicine, or did you envision yourself in a different specialty when you first decided medicine was your path?
Well, I've thought about this question many, many times, and I'm gonna try to give you maybe a new one that of kind of how I think now when I look back, because ultimately we sometimes make decisions without really thinking them through. But I think there was a grand design to all of this, which is that I always wanted to be in a very challenging specialty regarding the challenges of the patients we have to take care of and the very difficult situations that they would be put into. And so when you look at all different options when you go through medical school, there's few things as tragic as cancer. Now, acute trauma is also very tragic. The person was fine 2 hours ago. Now, they're missing a limb and hanging on for dear life. That's obviously tragic as well. But cancer really, for me, it seems like it strikes a lot of very innocent people who never did anything where they could get the cancer. And so then became the journey of what type of a cancer doctor did I want to be? Did I want to be an early detection, diagnostic person helping take care of people, cancer or treat them? And I started with a passion for being a surgical oncologist. And then ideally, really just, I don't know, it just wasn't a good fit. I love the people who worked in surgery. In fact, I did a year of general surgery internship when I had a choice to do an internship in anything before radiation oncology. But ultimately, I was very excited about radiation oncology because all the technology at the time, late 1990s, early 2000s, the microprocessor was still getting faster and faster. Images are getting better. The software technology that designed these treatments that drove these basically robotic, delivery devices was getting exponentially better every year. And so I wanted to be on the wave of what's been an incredible journey of technological advancements that deliver these highly effective, high precision X-rays to the smallest of tumor targets anywhere in the body.
Yeah, it's great to hear. And we've heard from you earlier that you've also helped oversee the VA PALS program, which has gotten over 20,000 veterans screened in 17 different centers. And many of these patients were asymptomatic patients who wouldn't have gotten screened otherwise. So what would you say are some of the misconceptions that people have about the VA?
Yeah, so maybe just a quick back note about the VA PALS program and why I got involved in a screening program. So VA PALS stands for the VA uh, 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 Partnership to Increase Access to Lung Screening, and it entailed a public-private partnership between the Bristol-Myers Squibb Foundation, the original LCAP team that developed lung cancer screening in the US, now run out of Mount Sinai, a bunch of amazing software developers and implementation folks, and then the Office of Rural Health in the VA, and then what was initially 10 VA medical centers, and ultimately we got 17 VA medical centers on board to increase access to lung screening. And people ask, what is a treatment doctor like a radiation oncologist doing involved in that? As a radiation oncologist, and now that I focus really a lot on lung cancer, I see a lot of people with advanced lung cancer, metastatic lung cancer, and I can spend the rest of my life just treating whatever comes in the door, or I can try to bend the curve so that the patients who actually see are all early detected, screen detected. And so if you want to do a major initiative, the largest healthcare system, integrated healthcare system in the US is, our federal healthcare system, which is the VA. It is designed to do large-scale research projects and implementation projects. So while the LCAP team has a global network of sites doing screening in multiple countries, 80,000 patients being screened, it took 25 years to get up to that number. And we were able to get, for example, 20,000 people enrolled in screening pretty quickly by developing all the partnerships across the VA. I think the biggest myth that people don't know about the VA, and it's not surprising that people don't know what's going on in the VA. It's a federal agency. It's got very high walls. The government doesn't want you to know what's going on inside to judge it and, trash it in the news. So it hides kind of what it does, just kind of to protect itself. But inside really is one of the best clinical environments to work in. There's this incredible brotherhood and sisterhood between all the people who work there. And of course, between the veterans who all served in the military to some capacity. Many didn't go to combat zones, many did. And at the end of the day, it just feels like you're in someone's living room or home when you're at the VA, and everybody wants to help each other, help the veterans who helped us. And because of that, there's this kind of like culture that you can do anything, including build a massive lung screening program such as like the VA PALS program.
Yeah, thank you for sharing, Dr. Moghanaki. And that's really incredible. I just want to really highlight for our listeners the stats again, the numbers again. But through the VA PALS program, you all have gotten over 20,000 veterans screened in 17 different centers. And I wanted to ask if you could talk to us about what you think have been the biggest factors behind the success of this program.
So, I have this network of pulmonologists who I work with on, some other projects, and, everybody wants to see earlier detection. And so there was this, we can do it, we need to do it mentality, but there was also a failure is not an option mentality. So in the military, right, when you're in a combat zone and people start getting wounded, the culture is you don't leave anyone behind, right? So these are the people we're taking care of. And so we basically had that same mindset. If you think you can quit, I tell you, a lot of things are difficult when it comes to implementation, especially when you're talking about getting, there's politics involved in all of this because we're a federal agency. The board of directors of the VA is Congress. So, if it gets to that level, now you're having even more difficult conversations. But we just built this culture of failure is not an option. We dealt with whatever was thrown at us, and we just kept climbing to make it a reality. And I'm so proud to say that we ultimately diagnosed over 350 veterans with early stage lung cancer, most of them treated with either surgery or radiation, who probably wouldn't have known about their cancer for many more years, often unfortunately would have shown up in the emergency room with metastatic disease. So I think it keeps coming back to culture and the willingness of people to want to work together in this healthcare system.
That is amazing. And I have to say, Jacob and I and the rest of the GW ALCSI team this weekend were able to see a little bit of that environment you talked about, leaving no one behind. This weekend, we volunteered at the VA in DC near Children's National Hospital at the Winter Haven, where we were able to talk to veterans, many of them homeless. And if they were eligible for screening and they were willing, we walked them down to radiology and got them screened immediately. So I know exactly, I mean, Jacob and I could both attest to that, and that culture of leaving no one behind that we've never seen anywhere else, or at least I've never seen anywhere else. It was
Yeah,
truly
there's
amazing.
true love, and it's real.
No, it certainly is. So the VA PALS program is now expanded beyond the Veteran Affairs health system, as there's now a Cal PALS program. How can we continue to expand these screening programs so that health systems in other areas can adopt them?
Well, I'd recommend everyone listening to this who's involved in implementation projects to always think about your sustainability beyond the horizon plan. So VA PALS, you know, we had dreamed and hoped and pushed so that VA itself would make screening a national priority. And on the heels of the VA PALS program, our leadership did make it a priority, asked for the funding, got awarded by Congress, and with $100 million spent, or even more to date, we now have, you know, over 112, maybe even 120, I can't even keep up, medical centers in the VA, all screening is now, there's now a national directive. Screening is not an option. It must be available, must be offered. And even the White House has been proud to say that, you know, the VA now is going to screen everyone at risk and going to screen, you know, over 1 million veterans who we think, you know, we've estimated to be at risk. And the VA has its own national center for lung cancer screening, a brand new office opened just in the last several years, staffed to make that happen. So that was kind of the horizon of the VA PALS program. So while I thought I could just ride into the sunset, get back to being a radiation oncologist, I was invited by the BMS Foundation to think about what can we do in Southern California. So in California itself, as a state, we're really doing poorly with screening. And it's almost ironic that here at UCLA, we haven't been able to solve, you know, the regional problem. The state problem obviously is a bit much bigger than one university. But that's okay. We're a higher resource institution, and we knew that with appropriate funding and a partnership, we could start what I'm hoping will be a revolution and change a way of thinking about lung cancer early detection across LA County. So as you might know, LA County is actually the most populous county in the country. In fact, it was a state, I think it'd be the 10th largest state in the country. So 40 states in the country have less people than we have just in LA alone. So if we can change the discourse here, we can change it anywhere. And so basically UCLA, with an incredible team of partners at the School of Medicine and the School of Public Health, with radiologists and implementation scientists and family medicine champion, we partner with 2 community hospitals who are taking care of people in kind of, you know, less advantaged communities who are marginalized. And we are going to help them build world-class lung screening programs, engage stakeholders to build the awareness and advocacy around it, to give CME talks at hospitals all around the area so that people think about lung screening, care about lung screening, and invite their patients to get screened. And we think that on the heels of that, we'll have the leverage to then just keep, you know, making this thing go viral, just like the VA PALS program did, so that all hospitals in LA County will make this a priority. You know, I use the analogy a lot with my colleagues regarding how to get something to go viral in healthcare. And I just remind them that if you look at penguins on an iceberg, they all just kind of like hang around. They all may get to the edge, but no one jumps in the water, right? Until the first one does. And then the second one. And then they all just kind of stream into the water. Now, why do they do it? Well, of course, they're worried about sea lions and other things that could eat them. But once they see that no one ate them, they're all fine all jumping in the water. And we're hoping with the California PALS program, which again, you may think, you know, it just stands for California Partnership to Increase Access for Lung Screening. I'm not trying to franchise this. I just couldn't think of a better name for our local area. If we can show how these 2 sites can do great, and we will publicize, we will really publicize it just like we did with VA PALS, so that everyone knows that what is possible. And I think that a lot of times what we do in academics is we focus on the reasons, the barriers. We keep publishing papers on barriers. I don't like that. I think we all know what the barriers are. Instead, I like to publish stories about what's possible and what's achievable, so that we can be a beacon of what is able to be accomplished by any healthcare system in this area, hopefully across the state of California and then across the nation.
You've spoken about this revolution that's occurring within LA County, and I know UCLA, the health system where you work, has already made, a lot of strides in increasing the number of people getting screened. But, work is never done, nothing's ever perfect. Is there still some changes that you think could be made or some areas of this program that could be tweaked in the future?
Well, so at the end of the day, like the data on barriers is crucial because that's where you go to find out what you can do, what needs to be addressed, where you can focus your attention. And, stigma and blame is still a big part of the what we call screening hesitancy. And it stems from, anti-cigarette campaigns that really use fear-based messaging. Now, fear-based messaging does work, but it leaves behind a cloud of kind of this guilt and shame that you didn't do what you were supposed to do. And I think that there's often a lack of empathy for people who are addicted to cigarettes, right? Especially family members. And we also see sometimes even in the healthcare system, the doctors get really frustrated at their patients that can't stop smoking. And I've talked to a lot of patients about this issue, and they go, "Look, doc, you're not the one who's going to get me to quit. I've been trying to quit for 30 years and I just can't." So I think addressing this to make it say, look, we know it's not okay, but we appreciate you can't quit. It's okay. You enjoyed smoking. You had your fun. Now go get your damn lung screened before you die of your lung cancer. Let's find out if you have emphysema or anything like that. So I would say that's really the broader message. We have a state-of-the-art healthcare system. You can get screened at UCLA if someone orders it. But the problem is it's not being ordered. It's not being asked about by the patients. And I really think that the stigma has a lot to do with it. It's the screening hesitancy isn't just the patients. There's also a lot of healthcare providers who just might be a little bit reluctant. They're not sure what the value of it is. So education, I think, is a way forward. Education for patients and education for providers that this is a good test to order to save lives.
Yeah, absolutely. I couldn't agree more. And one of the biggest concerns I think we get about lung cancer screening from patients is worry about false positives and any, additional testing that might come up with maybe a suspicious scan. And so could you talk a little bit about that, Dr. Moghanaki?
Yeah, I think it's pretty advanced for a patient to talk about that. I think it's really the providers that are driving that or are planting that information. And a lot of this has to do with the way that we grow up in the medical education system. There's been a lot of focus on, unnecessary procedures and tests, but lung cancer is a completely different league of its own. If you're a high-risk person who smoked 20-pack years, which is the equivalent of 140,000 cigarettes in your lifetime, what are we doing sitting there trying to be worried about, the risk of a false positive or, having to be called back to get another scan because of a benign finding that looks suspicious. Usually what happens is when you get a scan, the most common thing you find is just something that needs another scan. It's not a biopsy. And then if there's a lesion, it could be cancer. The value of getting a biopsy to find it and detect it and treat it as soon as possible, is huge because it comes down to saving people's lives. Now, there's a lot of effort being made to make sure we don't screen the wrong people, which is like really old people who are frail and close to death anyway. And I get it. We're not talking about them. We're talking about walkie-talkies in their 50s or 60s who, partied. They smoked a lot and now they've quit. They want a second chance on life. And these are the people we need to be screening because we've got highly effective treatments for them. So it's not clear to me why there seems to be in kind of an exaggerated focus on the harms thing. And I think it's because what we're taught in medical school. So I'm really hopeful that through contemporary education, we're more aware that the risk of, for example, if you take all comers who get a screen, a few will have lung cancer, most won't. And of course, we don't want to harm anyone who doesn't have lung cancer. But when you look at all comers, the risk of a harm versus risk of a saving a life is just, there's no comparison. you save so many lives with screening as a whole, that it is definitely worth it. This has been studied in randomized trials that considers the entire denominator. But I think what happens is sometimes people get confused. Of the few who get lung cancer, the treatments are tough. It's lung cancer. It's war. You're trying to save this person's life. They got a ticking time bomb in them. And sometimes what people do is they draw the data from those who had lung cancer and they spread it across a denominator who never had lung cancer and didn't have those complications. So it's really important to say, what were the complications of those who never had lung cancer versus those who did? And then really focus on those who didn't have lung cancer. Are they really getting unnecessary biopsies? Are they really having unnecessary surgery or unnecessary radiation or things like that? The numbers are really minuscule when you look at those who actually don't have lung cancer regarding the harms. Yes, lung cancer treatments can be harmful, but you're trying to save a life in someone who has lung cancer.
Yeah, I think it's really interesting to think about focusing on that data on like lung cancer, the harms of lung cancer screening, and really focusing on that data specifically. And now, like switching gears a little bit, I was wondering if you could speak a little bit more about what the VALOR study that you were part of was about, and what the results of your research in that study was.
Yeah, so I think there actually is a segue to what we're talking about. So one of the things with lung cancer is some of the treatments, not everyone is really fit to undergo lung cancer surgery. So surgery can be pretty tough in people who are, have bad hearts, weak lungs, have other ailments, live alone, would really need a lot of care, and, they end up in a nursing home instead of getting discharged after lung surgery, or they have an infection, or, and then there's a certain small percentage, not zero, but, small percentage of people who actually end up dying after surgery. They don't survive the surgery itself. So we need better treatments for the people who we can cure. And so stereotactic radiation has been around since the 90s, basically as long as since, robotic surgery and video-assisted surgery has been around. And very few people are aware of stereotactic radiation. And behind the scenes, radiation oncologists have been studying and evaluating it. And my gosh, it's outperformed whatever anyone had expected, to the point that we think it actually might be just as good as surgery and certainly safer. So since 2008, we've been trying to compare stereotactic radiation to surgery to see if we can move science and medical technology forward so that we don't always have to do surgery till the end of time. I mean, this is how back in the days, if you had an ulcer in your stomach before antacid pills that you now take and it goes away, we used to remove the stomach, right? So if we didn't do science, today we would be removing people's stomachs if they had peptic ulcer disease, right? So through science and research, we move forward, and now you go over to counter CVS and you buy a omeprazole and your ulcer goes away after a couple of weeks. Same thing with lung cancer treatment. We'd like to move forward, and stereotactic radiation really represents probably the next major historical milestone in getting our treatments to be safer and just as effective. And then in some day in the future, combining with different drugs to eradicate lung cancers altogether. So several different research teams across the world had tried to compare the two together since 2008, like I mentioned, and they all kind of surrendered around 2011. And there was another one in the UK that opened in 2015, and with the NHS funding, they failed as well. So you had kind of like three major randomized phase 3 trials just not able to get off the ground. And so I submitted an application for funding around that same time in 2012-ish. We were awarded in 2015, and in 2017, we opened. And we've been randomizing veterans in the VA healthcare system in a study called the VALOR study, which is the VA lung cancer surgery or radiation, study, phase 3, trying to enroll 670 patients. It's been open since 2017. And just like many other studies that are trying to enroll operable stage 1 patients, our study is also taking patients who are operable with stage 1 and half get surgery, but half get stereotactic radiation. And just a few weeks ago, we passed the 400 patient enrollment milestone on our way to 670. And to date, we review the data every year. We haven't seen any sort of a signal that one is better than the other. So we're continuing to randomize patients. And at the end of it all, it might still show that surgery is the better treatment, which is what we currently think, and the guidelines all recommend surgery. And if so, then at least we'll know that any risk of surgery is kind of, worth it because it's a better treatment. But stereotactic radiation might be actually the better treatment. In that case, we'll really have to stop and scratch our heads and figure out what to do, because we have really good outcomes after surgery. But if this study shows stereotactic radiation is better, we may rethink surgery altogether. And if the two are the same, then, it kind of allows us to have both options for every patient to make sure we pick the right treatment for each patient. There's pros and cons to both. And it'd be really nice to have more than one option as opposed to always trying to get people to surgery and then kind of reserving radiation for those who can't have surgery. That's kind of how current things are currently. But I'm very happy that the VA is sponsored and is running this trial. My co-PI is a thoracic surgeon at Duke, David Harpole. I love working with him, and together we're very proud of the team that's been enrolling all these patients. And we hope to finish accrual by 2027 and then wait to see what the results show.
That sounds amazing, that the future of treatment could be hopefully less invasive, less scary for lung cancer patients. We have some lung cancer patients who listen to our podcast. So I'm just curious, could you actually explain what the procedure is like for stereotactic radiation for those who might be interested in asking their oncologist or doctor about the procedure?
Yeah, so obviously, if a patient already has lung cancer, it wouldn't be their first treatment, but later on, if they develop, a new lesion, they would need stereotactic. It almost sounds too good to be true. You literally lay on a table like you're getting a CAT scan, and it doesn't feel any different than a CAT scan. The machine kind of rotates around you robotically, and it delivers these highly focused, high precision X-rays to a very small target that we draw on the scan. It's a three-dimensional target, and as the machine's rotating around, it's delivering this kind of very tiny spray painting beam of X-rays that scars down the tumor to stop it from growing and very often kill it. And in fact, we rarely see it ever regrow again. So we're very good at eradicating the cancer that we can see. Efficacy rates are, 90 to 98%, with some reports up to 100%, depending on the type of lung cancer and the size of it. But just like surgery, one of the biggest challenges for us is it doesn't treat what we can't see. So, after you do deliver this treatment, you got to do careful surveillance to see if there was any more cancer that was invisible when you treated it, to see if it shows up later. But yeah, I mean, the treatments usually for stereotactic radiotherapy, you can now get it in one treatment, sometimes up to 5, maybe 8, but it's just basically 6 to 7 minutes of treatment each time to deliver all of it to the tumors that we can see.
Awesome. Thank you for sharing, Dr. Moghanaki. And then as we start to wrap up the podcast, we just wanted to ask, we're recording this in November, Lung Cancer Awareness Month. Do you have any words of advice for any lung cancer survivors who may be listening?
For patients, well, so I take care of patients every day, right? So I would hope that they're being taken care of by a team of experts. I think that the good news is that you don't always have to go to a major academic center to get high quality care. You want to be at a place where you have all the different specialists within the specialties working together and are harmonious. You don't get good outcomes being taken by care by an individual. You get great outcomes by being taken care of by a team. And I think if it's like run-of-the-mill, situation, the guidelines now allow high quality care to be delivered anywhere. However, whenever there's relapse or difficult situations, you really want that team to be a lung cancer team. And in the community, they're just kind of a general cancer team. And I've been increasingly thinking about team-based care with regards to car racing. I'm not really much into car racing, but I'm just very fascinated by these documentaries about Formula One race cars and race car teams. And so anyone can drive a car, right? But there's very few who can drive these $6 million, 8,000 horsepower F1 cars around this track, round and around and around the same track. And the difference between first and second place is literally like fractions of a second, which has to do with hitting every turn perfectly over and over again. And the only way you can get that good is if you're not distracted by taking care of a lot of other cancers. So I'm very lucky with the team I work with. All we do is take care of lung cancer. We do the same thing over and over and over again. And when we see something slightly different, we quickly recognize it. This isn't normal. And so the guidelines are a good foundation, but all those micro decisions that you make, because not every person looks the same, I think you end up getting better care if you're taken care of by truly a world-class lung cancer team. So the situation gets complicated. You might want to make sure you get a second opinion from that kind of a team. If you can get care at that place, great. If not, that metropolitan team can help support your team closer to home. so that you're really sure that you're getting the best care that's available.
Awesome. Thank you for sharing. We haven't heard that piece of advice before. So, yeah, that's wonderful. And our last question for you, Dr. Moghanaki, is how can listeners get in contact with you?
Well, you can follow me on Twitter. I'm very active there. Just send me a direct message, and then yeah, we can contact you that way.
It's been a pleasure and honor to speak with you and just learn from the wealth of knowledge and experience that you have in the field of radiation oncology and lung cancer screening. And we just want to say that we appreciate all the work that you and the VA and UCLA are doing and the perspective that you brought to our podcast. To our listeners, thank you for joining us on this episode of the LC Podcast. We hope you enjoyed it. Please keep an eye out for any upcoming podcasts and events, which you can find on our website, www.lc.org. And thank you and have a great day, everyone.